I just want to make sure, I just want to make sure that I was recording. Okay, no problem. Okay, so let me go on. Um, we're going to discuss now. Let's see, we discussed the fetal heart rate. Okay, now management for abnormal patterns. You probably go, oh no, what is all this about? Okay, so we have some mnemonics here for that. And the first one for an abnormal pattern, what I mean by abnormal pattern is that the fetal heart rate might be have a deep variable or may have some late decelerations. I have to move mom in order what? To get more oxygen flow to the fetus. That's all it is. Okay. So what I can do is I'll start out here with lion. And this is a good one to remember. So you write down LION. Okay. So what we're going to do if we get an abnormal fetal heart rate pattern, I'm going to put mom definitely on a left lateral side. Don't ever labor anyone on their back. No, because you run into what? Oh, excuse me, you run into supine hypotension syndrome. I do not put a laboring patient, nor do I ever put a pregnant lady on her back, never in supine. So if I have an abnormal pattern, I'm going to put on the left side because that's the side that I get more blood flow to the baby, more perfusion. I have an IV going, so I'm going to increase IV fluids. And if she doesn't have an IV going, you're going to get an IV. I need a line in there. I need to get some fluids. I need to get that uterus hydrated. I need that. And if I need to give medication, I have to have accessibility. So you see why you would have an IV. And then oxygen. You have oxygen at 8 to 10 liters via tight face mask, or better yet, a non-rebreather. So in your labs at the college, go ahead and look at all the different face masks, and you can see how you would have a nice tight face mask on this patient or a non-rebreather. I got to get the most into her quickly. And then the end would be all the time notify the doctor, either, whoever the provider is, the physician, because I need to get help. Okay, you need help. Hey, get in here. Okay, now, if I have a medication going, such as Pitocin, I'm going to stop that Pitocin. That Pitocin, maybe you're doing an induction of labor and the baby is not responding well with his fetal heart rate. Maybe he's having some problems. You lost variability. Maybe you have a low baseline. So you have to stop the PIT because I want to stop the contractions because baby is not tolerating the contractions. And so I don't want to take a healthy baby and make a sick baby. So I'm going to stop the Pitocin. The position is preferably, again, left lateral. Oxygen, like we said. IV bolus. You have an IV, so I'm going to give her a little bolus of IV. And then L would be low blood pressure. I'm going to treat the underlying cause. So usually you give an IV bolus, you have oxygen and get her on the left side. You usually can get that blood pressure to come back up. And then if I need to, guys, I can give her a tocolytic. And what that does, that slows my contractions down. Maybe she got hyperstimulated or she came in with hyperstimulation contractions and the baby's not tolerating those contractions every minute and a half. So I'm going to give her tocolysis, which could be, I could give her some terbutaline and take care of that. What happens is that anytime the fetal heart rate is outside the normal limits, remember I said the normal limits are 110 to 160, and any slowing of the fetal heart rate that persists after the contraction ends, that's called a late. Okay. And that has to be reported to the healthcare provider. Okay. So if I have a patient that comes in and the fetal heart rate is outside the normal limits, either bradycardia or tachycardia, I'm calling a doctor. Okay, because usually tachycardia of the fetus is related to mom's temperature. So I'm definitely going to get her temperature and call the doctor and let him know that now I've got a baby with baseline of 170. Not a good thing. And then if I have, on the other hand, if I have any slowing of the fetal heart rate, if I have bradycardia, which is less than 110, then I'm going to call the doctor. Okay, something else is going on, and I want the physician there. All right, in case we need to do what? A C-section. Okay. And then if I have a baby that has the heart rate after the contraction now, the fetal heart rate decells, then that's called a late deceleration. And remember, late decelerations are caused by placenta insufficiency, and that is never good for the fetus. Okay, so you can have a healthy fetus, but then he starts having these late decelerations. That means the placenta is no longer delivering, and that could be that she's 42 weeks. Remember, we discussed that, or it could be someone who's a diabetic, and now she's having problems. So these are things that can happen and affect what? The life of the fetus inside. So whenever a baby's in what we call a hostile environment, it's good to get the baby out. Okay. So those are what we call abnormal patterns. All right. All right. So let's go now to some non-pharmacological pain relief measures. Now, guys, we have been emphasizing this quite a bit. So I would take note to the different ones. It could be like an all but apply question. So I would know these. And so here you go with your relaxation techniques, touch therapy. We talked about that. Effleurage. We talked about that. The sacral pressure. A lot of times moms in the very beginning of labor have a lot of low back pain. And that's because maybe the fetus is in a position called occipital posterior. And that means his little chin is sticking right up in the air down there in that pelvis. Ouch! That kind of makes me go, ouch. And what happens is that the occipital part of the baby's head is facing mom's back, and that she has really hard back labor. Well, you can have the partner do some sacral pressure, and you take like the palm of the hand and you push it right against the sacrum, and boy, that really relieves a lot of that pressure. A lot of times too, I used to take a bedside table, put a pillow on top, and have mom lean over, and if you kind of can see, I'm stretching out my back, and then the partner can do the sacral pressure. That really helps. And what we want to do is when a baby's in OP, we try to keep mom walking, especially during the latent phase. Keep mom walking, maybe, so that she would hopefully change that baby's position. Okay, and you can see the couple on this picture here. They're in like a whirlpool, and that's really nice. A lot of times I'll have mom have the water that she's a little bit down deeper, and then the water is over the belly, and that nice warm water really helps. But this again is that's called hydrotherapy. And I told you that I used to have my patients in the shower. That really does help relieve back pain and promotes dilation. Okay, and then of course ambulation. We talked about walking, and we talked about positioning, and diversion and distraction. And in the labor rooms today, there's can be a lot of distraction. You have family members in there. And diversion, you have TVs, you have all kinds of different things. You can divert her attention away from the pain and have her maybe concentrate on something else. I had patients that used to play cards. And then when she get a contraction, she was concentrating on her cards so much that she actually was diverted from the pain. It's all according to your patient. And then breathing, and we talked about the breathing techniques. That does work. And you have the 3 different types of childbirth preparations. You have the Bradley method, and again, you have the Lamaze method, and then you have the Dick Reed. And they're all kind of a combination, but they all promote controlled breathing for relaxation and to basically handle these labor pains. And then you have the hydrotherapy I talked about, and cognitive, and you have massage. All right, so those are called non-pharmacological, and that means that there's no medication involved. Okay. All right, so we have maternal comfort and coping. So labor support. Okay, again, it goes over the same thing I just went over, perception and expression. So according to your patient. And remember, pain is very subjective. So if my patient tells me that at 2 centimeters or even 1 centimeter, so she's in pain, she's in pain. I respect that. But I knowing that basically she's in the latent phase of the first stage of labor. So what am I going to do? I'm going to help her get through by doing those non-pharmacological means of pain relief. Okay. All right. And that's what these are: position change, distraction, psychological, the anxiety. Some people just have high anxiety. And so you really got to work with them in order to distract them. And then breathing. Now, before I think I went over this, but you want to have the control breathing is because I don't want my patient to do that rapid breathing all the way through a contraction. Okay, because what will happen, she will hyperventilate. And all of a sudden she gets numbness around her mouth and she gets tingling, and that scares them. Okay. If they had any kind of anxiety before that, they'll definitely have it afterwards. But you really do get scared about hyperventilation. So what can I do? Well, if she has a little brown paper bag in her, her childbirth bag, then we can get the brown paper bag and we put it over the nose and the mouth. If she doesn't, I usually tell my patients, take your hands, cup them, and then put it over the nose and the mouth, just like I'm demonstrating to you. And then what? Breathe normal. That does work. So that's cool, and so I want to avoid that because that will cause them to have more anxiety. And I always, I'm teaching my patients, I'm explaining things to them before I do anything. Before she has an amniotomy, say, an AROM, which is artificial rupture membranes, I'm going to tell her, I'm going to explain to her when the provider comes in what's going to go on so that she is not thrown off guard. Okay. I'm also going to provide encouragement. Now, we have a woman that is a doula. Now, doulas are great. Okay, doula is a woman that can provide emotional and physical support. A lot of retired L&D nurses go on and to get a certification of doula. I myself did that. And so a doula just provides emotional support. They're not in the room during the labor and delivery nurse. No, they don't have to be a nurse to be a doula. But you're giving support. They understand the labor process and what they're doing. They're giving support, and they're like the patient's advocate. And so the L&D nurse works along with the doula. We all get along, put it that way. And though the L&D nurse is the one in charge in the room, and the doula is there for support. Okay. And two, she's the one who can get in the shower with your patient if you're doing the hydrotherapy. And non-pharmacological, we went over all these. As you can see, these are things that really do work. The counter pressure helps with back pain. The therapeutic touch, which is your massage and your touch therapy. Effleurage, I already went over that already. That's light massage, stroking, and a circular motion on her abdomen. And combine it with a pelvic rock. Perfect. And then you have hot and cold. You have water therapy. I talked about the hydrotherapy. Some hospitals have a whirlpool. Some have showers. And so that's okay. And then sensory, you have aromatherapy. A lot of times they'll bring in those little aromatherapies and we can hook them up. That's good. And like lavender is very relaxing. Imagery. I use a lot of imagery with my patients as to help them understand how the cervix dilates and opens up. I compared it to a rose. A beautiful rose, how you can see how the petals would just open up beautifully. And they usually get that imagery. And breathing techniques I talked about, and of course focal points. I always ask them to look or stare at a wall. You can see like a little spot on the wall, and that can be your focal point. Is when you're doing the breathing, if they need to look at something, they can have a focal point. Sometimes they use their husband as a focal point. And then cognitive, you have your childbirth education classes, and then you have hypnosis. Okay. All right, so those are different non-pharmacological pain management. All right. All right. So how to recognize and correct hyperventilation. I think I already did this, but I'm just going to go ahead and go over again. It's just signs and symptoms of hyperventilation, dizziness, tingling of hands and feet, cramps and muscle spasms of your hands. Okay. And I told you numbness around the nose and mouth, and you might see this again. So I'm just it just good to go over it once again. So dizziness, tingling of the hands and feet, and then numbness around the nose and mouth. Now, sometimes it gets really bad. You can have blurring of vision. I don't want to get that. I don't want to get to that point. Usually when my patient says that they're feeling dizzy and have tingling of their hands and feet, I know we have hyperventilation. Okay. Now, how are you going to correct it? Breathe slowly, especially when exhaling. Breathe into a cup hand. I just went over that for you. And then place a moist cloth, washcloth over the mouth and nose while breathing. Well, you could do that too. And then hold breath for a few seconds before exhaling. And then you want to slow down the breathing because that's what got you in the bad place of hyperventilation before, is just too rapid breathing. So you have to really work with the patients. Okay, let's move on. So this is about anesthesia, and I kind of already discussed some of these, but you have different types of anesthesia. You're going to have the local, where you just go ahead and see the needle here, just local right here. It just numbs up this fourche or the perineum. Then you have the pudendal, which you're going to go ahead a little deeper, and you got a bigger, longer needle. And what you're doing, see the nerve, the pudendal nerve? I'm just going to go ahead and numb that up, deaden it. And then you have the neural axle, which is a sensory blockage. And what you're doing on all these, you have to interrupt the conduction of nerve impulses. Okay, so that gate theory. So we want to go ahead and block them. And a lot of this, they don't have really lasting effects on the baby, which is good. And the main thing is about an epidural. Let me go back. The main thing about an epidural, it can cause hypotension. I would go ahead and write that down, hypotension. And what you do is I can give an IV fluid bolus before the epidural. So here's a patient that's sitting, and of course the nurse would be holding her, because this here is she's probably not pregnant, I don't know. But anyway, the nurse would be in front and coaching her because it's easy for her to move. I don't want this patient to move at all during the epidural. And not forget, now she's in labor, so she's going to have those labor pains. So I always tell my patient, just breathe with a contraction. I tell anesthesia, okay, she's got a contraction. Sometimes they go ahead and just pause and then wait for the contraction to be over, and then they continue. The main thing is I don't want her to move because I don't want that spinal needle to go more into the spinal canal. Okay, because what happens is that you can mix with the cerebral spinal fluid, and I do not want to do that because she'll have a terrible headache after delivery, and I don't want her to have a spinal headache. So again, for an epidural, if they're not hypertensive, I'm going to go ahead and give an IV bolus. Because why? Because I want to prevent hypotension to a normal tensive woman. Okay, so I want to make sure that everything takes effect, and we can use a epidural, one for labor, and if you have to end up with a C-section, then it's good for a C-section. Remember, if she moves, she can cause herself to have a headache. All right. And those headaches are terrible, and you have to correct them with a blood patch. Okay. And let's go on. So now you have that was anesthesia. So now you have pharmacological pain management. So you have analgesia, which an analgesic alleviates sensation of pain. Okay. And so you may always remember that it crosses the placenta. So we already went over the proper time to give these kind of medications so that the baby comes out okay. If if you give a narcotic, it can affect the fetus if she delivers within 1 hour. So you have to be very careful with that. And what are you going to have at bedside? Narcan. Okay. And so we want these babies to be breathing beautifully at birth. They come out because I told you that's their job. The biggest job of a baby when it's born is to breathe. Okay. So you got to make sure the timing is correct. All right, let's go fast over the inspection of amniotic fluid. We kind of did this already when I talked about AROM, which is artificial retromembrane, and spontaneous retromembrane is SROM. Okay, so the amniotic fluid should be clear. Now, sometimes they can have those little flecks of white flecks in there, and that's the Vernix. That's because the baby slept them off. Okay, now you know the Vernix is the nature's cold cream, and Langugo is the little fine hairs that's on the baby. Now that you can see in that when she has an AROM or an SROM spontaneous, you might see that. Now, if she has a yellow in color or cloudy amniotic fluid and has an odor, you got an infection. Okay, it's not good. So remember, color is normally clear for amniotic fluid. If you have green stain fluid, that means that the fetus passes meconium, which is the first stool. Now, this can cause meconium aspiration syndrome in the newborn. Okay, so we talked about this, and your role in the labor room would be what? To make sure that the wall suctioning is working. One, there's nothing worse than having your wall suction not hooked up and working. And then odor. Okay, amniotic fluid normally does not have an odor. Okay, an odor indicates infection, and then the amount, it can range from scant, which is a trickle, moderate, which is approximately about 500 mLs, and large amount is greater than 1,000 mLs. So there you go. So when you're charting, you want to make sure that you record the time of rupture, the color and amount of the fluid, and monitor for fetal heart tones for a full minute. Okay, so we kind of went over that. So that's kind of a repeat, but that's okay. It's always good to hear it over and over again. Now, cesarean birth indications. This is reasons why you would have to do a cesarean. All right. So you got a breech or a malpresentation. We talked about that. Shoulder coming, presenting, transverse lie, breech. Those are your indications for a C-section. All right. Abnormal labor, dysfunctional labor, labor dystocia. You just can't get that uterus to contract the way you want it. Every 2 to 3 minutes, lasting 60 to 90 seconds in duration. And she just can't, the baby's not coming down. Oh, here's the next one. Here's the baby's not coming down. Inability of the fetus to pass through the mom's pelvis. Baby's just not coming down. Maybe his head is too big. Maybe she's got a android pelvis. It's more like a male pelvis, and or a planetoid, and she doesn't have that beautiful gynecoid pelvis. So maybe just too big too. Maybe it's a macrosomic baby. Just can't get through. Okay, that's another indication. What? For a C-section. Then you have maternal conditions such as gestational hypertension or diabetes. All right, so these are all indications for a C-section if you need to. Now, active herpes is a C-section. Active herpes. A previous surgery on the uterus. Yeah, if you have a previous scar on the uterus, you don't want her to go into labor. Especially if it's a classical scar, you don't want them to go to labor because they can have uterine rupture. And then if you have fetal compromise, if you have late decelerations, that's never good. And you end up with a C-section, have to get the baby out. And then if you have placenta previa, or you have abruptio placentae, you're going to have a C-section. Again, why? Placenta previa, she'll bleed to death. You can't labor her, okay? And because the placenta is covering the internal os. All right, and then you got abruptio placentae. That's a septical emergency, and that's because the placenta is coming off the what? endometrium. Okay, so you got to, and these, and then placenta abruptio, it will be decreased oxygenation to the fetus, and therefore the fetus will be compromised, and you could have a healthy baby, and then you end up with not a healthy baby. And worse, if it's been going on for a while, you could have a baby that it has expired. Or could expire quickly after birth. So you got to get these babies out. So here's a nice little picture of a cesarean birth where they go ahead and do a trans-abdominal incision of the uterus. And these are good. As you can see here, the low transverse, we call that what? The bikini cut. Okay. And then you have a low vertical here through the skin. And what you have to worry about really is what's on the uterus. Okay. So many risk. C-sections is major surgery. Okay. I've had patients say, oh, she just had a C-section. That's major surgery. Any surgery is major. Any surgery, mom can get infected. Okay. You can have injury to other organs, such as the bladder. You can nick that bladder, and then she's got problems there. They have to actually bring in a urologist and sew it up. Okay, so that's why we put Foley catheters in before we go into surgery, is to what we're doing, we're deflating the bladder. And then, of course, baby can have injuries, asphyxia, even respiratory. You think that babies, when you grab, we go in and we grab the baby and we bring him out, and he still has what? A lot of fluid. And we suction the baby, but they still have a lot of fluid. That's one thing about a vaginal birth, is that when they come down through the pelvis, they're actually pushing out a lot of fluid out. And you actually see babies, they'll have fluid come out of their nose, their mouth, the ears, everything, is because they've been living in fluid. Okay. And then you have anesthesia. You can have a spinal, or you can have epidural, or you can have general. Now, general is usually when we have what we call a splash and dash type of C-section, where we splash the betadine or chlorhexidine and get in there quickly. That's when somebody comes in, fetal heart tones are very, very low, like in the 80s, 90s, and no variability. That means that baby has been in problems for a while. So you got to get the baby out as soon as possible. Or I have a lady that walks in the door and has a prolapsed cord. She didn't know she had a prolapsed cord, and now she's got problems with fetal heart tones. So these are definitely stat C-sections. An epidural, you have to have time to put that epidural in. So that's good for the labor in the labor room. And if you end up with a C-section, you just make the level of numbness a little higher, goes right underneath the breast, and then you're ready to go. Now, spinal, a lot of times they'll do a spinal, it's quick, and they'll go in, push in, and then as soon as they're in and they deliver the medication, she's numb. So you have to lay her down. And I usually do that in the operating room just before the C-section. They all have their risk, just like any other surgery, but you can get a spinal headache from a spinal, and she can get a terrible headache from an epidural. Okay, now nursing. Well, what you're going to do. So this is what we call intraoperative care. So before she goes back to the C-section room, the operating room, we're going to get her labs. Want to know her CBC and get a UA and coagulation studies. Good to know. All right. I want to know I want to know her platelets before I operate on this lady. Then you have your urinary catheter placement, I told you, to take down the bladder. And then we want to prevent bladder trauma. I've seen that happen where we had to go ahead and to inject methylene blue and to see if it comes out in the Foley catheter, so you can tell. So you don't want to get there. It's because then if you have a problem, you have to get a urologist. So I'm going to put that catheter in, make sure the bladder gets deflated. And then you have immediate post-operative. So post-operative means after the surgery. And so I'm going to take her vital signs. I'm going to look at the incision. or they usually have a big old dressing on it. And if I do see some seepage on my dressing, I'll take a little pen or pencil and I'll just draw a little circle around that. And what I'm looking at is during the time I have her in recovery, if she's still bleeding in that spot, the blood will then go beyond my little circle. Then I know that I got a little problem. And that's really a nice way to know if you're still bleeding underneath there, because usually surgeons like to take off their first dressing. And then you have to make sure that her fundus stays firm. These patients too can bleed. Even though we do a lot of suctioning during a C-section, they can bleed by that fundus. Remember, fundus has to be firm. And so on a C-section, yes, in the recovery room, I'm going to take my two little fingers, put it on top of that fundus. And if I can't feel that fundus, I'm going to have to do some frontal massage. Now, granted, I try to do a gentle frontal massage, but my responsibility is to keep that fundus firm. And then, of course, you're going to assess the lochia, and lochia is your drainage, so you have lochia rubra. And I would take note to the different lochias. So lochia rubra would be like your first 2 days. Sometimes some books have it 2 to 3, but it's the first couple days. It's really bright red bleeding. Okay. And then what happens, and you want to do assessment on that. So if you see when you massage the fundus, if your lochia comes out, and it's because it's going to be bright red, because fresh blood, if you have any clots. Okay. And then let me go back to the lochia. You have, so lochia rubra would be the first 2 days, sometimes, as I said, 3, according to what book. Then you go to lochia serosa, and that's serosa. And serosa goes from day 3 to about day 10. And then, the color of that is like a pinkish. So it's not that bright red bleeding anymore. It's mixed in with some mucus, and so it's pink. Okay, and then every day after delivery, she'll see less and less. Okay, and then of course that you have to measure intake and output on these patients. So it's major surgery. All right. Now, before we were talking about the labor process, I was also telling you about vacuum-assisted births. So here's a nice picture of a vacuum-assisted birth. And what happens is, see the bone right here? Sometimes the head gets kind of stuck. She just can't push, And if you had a patient who's been in labor a long time and now they're ready to push, they really get tired. After a few pushes, all of a sudden they get really, really tired. So we can do a vacuum extractor, we can see. And again, it's negative pressure to assist the birth of the head. What's the requirements? Well, first of all, she's completely dilated because we never push before 10 centimeters. The head is well engaged. And of course, she's in a vertex. You don't put a vacuum extractor on a breech. Never, ever, ever. And then she has ruptured membranes, of course. And then you have no suspicion of cephalopelvic disproportion, or CPD, because you're not going to get this baby out if you have CPD. That means that the baby's head is in disproportion to mom's pelvis. So you're not going to be able to pull that baby out. No, this is just like an assisted. That's what we call it, a vacuum assisted birth. Mom pushes and the doctor has this vacuum on, and they're using negative pressure to assist the birth of the head. Okay. Well, there are risks for mom. A hematoma, like I talked about before, the collection of blood in the vaginal area, it is very painful. I've had patients that had that, and I'm going to tell you, oxycodone or Percocet does not even touch it. You can have lacerations, as we talked about, and so there is risk. So they have to be very careful. The practitioner, whoever's using that, has to be very careful as to not to harm mom's tissues. Now, the risk for babies, we talked about the cephalohematoma. and subdural hematomas, which is never good. And then you have scalp lacerations. And, I hate to tell you, but if you don't do this right, you can cause a seizure in a baby. So we got to be very careful. You can see the circular edema on the scalp. So you could have septal hematoma, which is never nice. And then you have, because of the septal hematoma, you could have hyperbilirubinemia, hyperbilirubin. And that will then lead, of course, to that neonatal jaundice. So it's risky, but you only do it if you can. If that baby's too big, then you don't do it. All right. And here's your perineal repairs. And of course, again, going back to episiotomy. Now, again, episiotomy is a controlled surgical enlargement of the vaginal opening during birth. And what's the indications for this episiotomy would be better control over where and how the vaginal opening is enlarged. Okay, so you got a head that needs a little more room. You're going to go ahead and do an episiotomy. And it's always better to have a clean edge. Like I always said, the surgical cut rather than having a ragged opening. A tear is much harder to repair and to heal, because a tear is it is jagged. So we have different degrees of this type, and you basically have your first degree, second degree, third degree, and fourth degree. Okay, now what do you think on a fourth degree, where you have this laceration extends through the anal sphincter into the rectal mucosa? Okay, well, that hurts. Ouch. So what do you think would be a dietary consideration? Well, you want to make sure she gets plenty of fiber and, of course, increased fluids. And then she could have, for pharmacology, you can have like Colase, stool softener, and with a laceration or an episiotomy, they're both very the patient doesn't want to have a bowel movement. Okay, so you got to help her to get over that fear. And so on your first degree, as you can see here in the pictures, you just have a superficial vaginal mucosa. You see her little cut there? Okay. Now, either she has a prudental anesthesia, or she has that local that we put in here to numb this area. And then the second degree is a little bit deeper. So now you get the perineal mucus in there, and so is mucosa. So it's a little more deeper tissues of the perineum. So you can see how it opens up more. So if you've got this big old head coming through, you can see how that would give more room. And then third degree is also, now you're going deeper. And so now you've got the anal sphincter that's involved. And then fourth degree, we call this a C-section from below. As you can see now, it goes back into the rectal mucosa. This is pretty tough. Okay, so you definitely have to have an increase in the fiber, okay, in their diet, okay? And you have to explain to them that to do pericare, of course. All right. Okay, so that does hurt. So they'll be wanting some comfort measure, such as maybe some oxycodone. All right, so what are you going to do? So when you're a nurse on the postpartum mother-baby unit, you're going to have to remember to, every time you look at the episiotomy, laceration, you're going to have to look at it pretty intense. So I want to chart the following. I'm looking for redness. So we use this mnemonic. It's called REEDA, R-E-E-D-A. So you want to write that down, R-E-E-D-A. And next to R, I'm looking for redness. Remember, I'm the nurse, I'm postpartum, and my job is to make sure the episiotomy does not get infected. So, and it's healing, and the sutures are well approximate. So I'm going to check for redness. E, I'm going to check for edema. The other E is ecchymosis or bruising. okay? The D is for discharge, and the A is for approximation. Approximation is where the tissues are coming together and they are approximating perfectly. Now, because don't forget, this is down the mom's bottom, so sometimes they get a little loose. So you have to make sure they're well approximated. So this is my postpartum perineal assessment. So this kind of mnemonic really helps you think what you got to look for. All right. So if I have edema and ecchymosis, I can apply ice for the first 24 hours. Did you all hear me? Ice for the first 24 hours. Okay. That is your best anti-inflammatory. That will decrease the amount of edema. Because when they have a lot of edema, they have a hard time urinating. So I want to make sure I get that under control. And then, of course, the bruising, the ice helps on that. And the discharge would be what? Your lochia. And also in the episiotomy, the discharge would be what? If there's any purulent discharge, I need to chart that because I'm thinking what? I'm thinking infection. And then, of course, approximation. So you always check in the episiotomy when you're working mother-baby units. And so I'm checking the episiotomy. I'm checking on the tearing. I'm checking to see also if she has developed a hematoma or she has a hematoma. And then hemorrhoids. Hemorrhoids are not fun. A lot of women during pregnancy do get hemorrhoids. So what are you going to do? Well, after delivery, during the pushing stage, the hemorrhoids kind of blossom out a little bit more. So after she gets on mother baby unit, you can get what we call tucks, which is a really nice. After you clean everything, after you have a urination or you have a bowel movement, you use the peri bottle. Clean the area very well, pat dry, and then you can put your epifoam on the episiotomy and then tucks on the hemorrhoids. Kind of nice. All right. So again, healing is like any other surgical incision. We're going to teach cleaning with that peri bottle. It's a little peri bottle. It's a little kind of a squirt bottle, and you put some nice warm water. And every time she urinates or have a bowel movement, she's going to clean the area. The thing about episiotomy is that you got to keep it clean. And then listen up. I'm going to teach her to consume high fiber diet. Keep everything moving in that colon. Why? Because I don't want her to get constipated. Because she gets constipated. Could you imagine if you get constipated, what you could do to that episiotomy? Not good. And if you have big hemorrhoids, what are you going to do too? You're going to make them even get bigger. So I don't want her to do that. So I'm going to make sure she consumes a high fiber diet. I hope you heard that. And then inspect the perineal area with her on her side. You got to look, and sometimes lady go, I don't want you to look down there. No, I got to look because and I always put my patient on their side so I can have one leg go up and I can support it with my shoulder and let just get a good assessment. That's my job working mother baby unit is to make sure I keep my mom nice and healthy. Now, you have comfort measures. I told you about ice pack for the first 24 hours. You got that peri bottle every time she urinates or have a bowel movement. And then after 24 hours, we have these what we call sitz bath, SITZ. And in your book, there's a really nice picture of it. And that is a lovely comfort measure. And she can have warm water and you can sit there and just let the warm water flow over the episiotomy. And those, as I said, it's a really nice, very nice comfort measure. And then she goes home with it. She gets her own sitz bath and she can take it home. And then, of course, I already talked about witch hazel pads like Tux, and then benzocaine spray, which is all very nice. And you have the Epifoam and Duraplast. It's all according to where you work. Okay, so that's how you take care of that episiotomy. All right, now we're going to go into the newborn. All right, so hang in there with me. So now we're nursing care of the newborn, and it's called the APGAR score. Now, just to let you know, Dr. Virginia APGAR is the doctor who came up with this. And why are we doing an APGAR score? We do it so we know what level of resuscitation that infant needs at birth. Remember, biggest job that baby has is what? Breathing. And then, of course, your heart rate, you have your different ducts that will be closing. So you're going to look at the infant. And this is how we do it. So here it is, APGAR. And then so A is for appearance. Now, it's a scoring system, folks. So we have a score of 2 if this baby is nice and pink. But look at the little drawing here. The baby's hands and feet are all pink. Okay. Then a lot of times you don't have this because this is more what we see. We see what we call a baby born with acrocyanosis. All that is that the little hands and the little feet are what? They blue, okay? That's because, remember, we have those different shunts of the heart that have to close and have to reverse the fetal circulation. So it takes longer for blood to get, what? To the extremities. Does that make sense? Yeah. So that's okay. So that's called acrocyanosis. Okay. Now, if the baby comes out and looks like this, okay? Now, this is blue or pale. A lot of times Hesse will use that descriptor, pale. That's a score of 0, all right? Because this baby is not circulating like it should. The blood's not circulating like it should. So there could be something going on with this baby. All right. So then you come down to pulse. So we're going to assess the pulse. So if it's greater than 100, hey, I'm going to give this baby a 2. Okay. So that means that we did our job very well during the labor and birth process. Now, if he comes out and he's got a heart rate less than 100, okay, he gets a 1. But he still gets a 1 because he has a heart rate. You can palpate a heart rate. Okay. Now, if he comes out and he's blue and he's got no pulse, you can't assess that pulse, he gets a 0 because you don't have any pulse. Does that make sense? Okay. Now, G is for grimace. Okay. So he cries and pulls away. That's a 2. Okay. Now, he's got a weak cry. All right. And he grimaces, his weak cry. Well, I give him credit. You got to give him credit, right? So we're going to give him a score of 1. Now, if he has no response to your stimulation, like, you take your fingers, and I used to flick the bottom of the baby's foot to kind of give him, give me some kind of response or reflex, then he gives me nothing. He gets a 0. So far, this baby here on the end here is not so good. Okay, now activity. If my baby comes out and they have all this active movement, their hands are up in the air and their legs, because don't forget, in utero they were all really compact, and now they're birth, and you put them on the radium warmer, and now I don't have anything, my hands go any which way I want. Before I had mom to hold me tight. Now I have nothing. So that's what happens. But look at that active movement. I give him a 2. Good baby. Okay. Now, if he moves his arms and his legs are flexed, then I give him 1. Yeah, he's moving, but he's not moving like I want him to move. I love this active movement. So I give him a 1. Now, if he's laying there flat with no movement, he gets a big fat 0. So again, I don't like this last column. And then respirations. This is my baby, All right, how am I going? So I'm going to assess. So he has a nice strong cry. Good. He gets a 2. I like, so this baby here under 2, there's all this right here, this first column. I like this baby. Okay, now, if he's slow and has an irregular cry, he's just not, he's not, he's having a little rough time, then what he gets is a 1. If he's not breathing at all, he gets a score of 0. Okay, so that's where your APGAR. So in the score of 0 of this last baby, you would be doing full measure resuscitation efforts. Okay, full measure. On the score of 1, he just needs moderate amount, okay. He may, a little stimulation, maybe slap that foot a little harder, and bring him around. Maybe, usually those babies come around. Maybe mom got a narcotic and she delivered very quickly on you. Maybe he had a rapid descent, and so he's a little slower. So you might want to, if she had the narcotic, you want to maybe stimulate this baby and maybe have to give Narcan. Now, this baby, this pink baby here, score on the twos, he doesn't need much. No, just maybe blow by, oxygen, and make sure you get dry. So, we are always concerned about thermoregulation. So make sure that he doesn't lose too much heat through what? Evaporation. So you want to dry him off. Okay. Now, the thing is, you assess at 1 minute and 5 minutes, and then every 5 minutes up to 20 minutes after birth, if the APGAR score is less than 7. Okay, so less than 7. So you can do your own calculation. If it's less than 7, you need to watch this baby, okay? This baby needs some extra care. All right, so that's your APGAR score. And again, it's just your level of resuscitation that you need. All right, so let's see here. That was my APGAR. Let's see over here. So care management for the first 2 hours would be of this baby, assessment of risk factors. Now, you're wearing your gloves. We always wear our gloves because baby has been in, there's a lot of amniotic fluid, there's a lot of blood, and so we don't want, get our hands into that. Assessment of risk factors. Okay, I always want to know, especially when taking care of a baby, what kind of labor mom had. That's very, very important. How many weeks gestation is this baby? Does this baby have meconium in utero? I need to know that. Pre-existing conditions. If mom is GPS group beta strep positive, did she get antibiotics during labor? Was there vigorous dry? If I'm going to dry this baby off, because again, I want to make sure this baby stays warm. Let me tell you, babies lose their body heat very, very quickly, and they lose it through evaporation, conduction, convection, and radiation. So you want to make sure that you dry this baby off. Okay, suction, mouth, then nose. Now this is sometimes a good question. And so I always say Mary before Nancy. Okay, so M. So also you can remember this is I used to tell my students the mouth. The mouth is bigger than the nose. So go for that. So suction the mouth, then the nose. Okay. And then the APGAR score, you do it 1 minute and 5 minutes. And that's on a normal baby. And then report any kind of signs and symptoms of respiratory distress or heart rate less than 100. Okay. And then, of course, you want to give the baby, below APGAR of 7. You want to make sure that you're using the correct resuscitation methods. Always cover the head with a little cap. Yeah. And then initial physical assessment on mom's abdomen. Yeah. We do family center, nursing. So baby comes out and he's, somewhat pink body, but blue hands, that's okay. Once the cord is cut, I put baby to mom's chest and skin to skin, and that's to initiate the bonding process. I can do my initial assessment. I can check heart rate. I just put my fingers on the cord and count. I can check the respiration. Baby's crying, or and you got the color. So you can do that when baby's on mom's abdomen. And also what we do too is that when the baby comes out, they go ahead and drain cord back. Whatever blood is in that cord, they kind of they wait a few seconds, minutes before they cut the cord so that more blood gets back to the baby. Then you want to look at the cord and how many vessels. So and a normal cord is 3. There's 2 arteries and 1 vein. So remember that mnemonic AVA, right? AVA. And then you have cord blood, and you have to collect the cord blood. And we're going to test for RH and blood type. And of course, sometimes if the baby has had problems during the labor or had a hard delivery, had long pushing stage, you might get a cord gas. Okay. Now here's your 4th stage of labor, and really nice. And just remember something. 4th stage of labor is the first 2 hours after birth. Write that down. Note it. And then you're going to assess blood pressure and pulse on mom every 15 minutes. Yeah. And then you want to evaluate and intervene for pain, of course. And she's recovered from anesthesia. So, from either epidural. If you got an epidural, folks, you don't get your patient up right away. You have to assess if she's able to get up and hold herself up. Okay, so you're going to be testing to see what kind of feeling sensation she's getting back. Always put an ice pack to the perineum. And again, because no matter what, you had a head that came through that very soft tissue. And so it will get edema and it will get bruising or ecchymosis. So you want to put a nice ice pack. And bladder. We always assess for distension because you give a lot of fluids and the bladder does fill up. And say she had a Foley in because she had an epidural, but we're going to DC that Foley while she's pushing because it's just too much pressure on the urethra. So we're going to go ahead and so the bladders can fill up very quickly. And sometimes what they'll use a red rubber catheter at time of delivery and get whatever fluids in there, get it out. So it's nice and deflated. All right. And during the 4th stage of labor, we're assessing that fundus of that uterus. Okay. If it's not firm and it is boggy, we're going to massage it. Okay. So when we do our assessment, we want to make sure that that fundus of the uterus is firm and not boggy. Okay. And if it is boggy, here it is, massage, massage, massage. What we're doing is we're identifying and preventing a hemorrhage. That's what we're doing. Okay. And if she continues to have a lot of bleeding, you want to tell your provider because what happened, remember I told you, you look at the placenta, make sure it's still all intact. If something's missing, it could be that it's still up in the uterus. And so then you would end up having retained placenta fragments. Facilitating breastfeeding, yes. Okay. And what that does, that helps to produce more oxytocin. Because once the placenta is delivered, you're going to give Pitocin through the IV. And so to make the uterus contract. So I can make that uterus contract even more, which will give me a nice firm fundus. So I'm going to make sure, let's get this baby on the breast. And it's really nice. And you start having the bonding process where you want that emotional tie, okay? And then you're promoting bonding, which will lead to attachment. And then we do the skin to skin. And so let that beautiful baby feel mom's beautiful skin. And then, of course, then you got your care of the newborn. Okay, so before baby leaves the labor room and goes to the nursery, you're going to have the bands on the baby. So you're always going to put two bands on baby, one on his wrist or his arm, and then one on the foot. And then you have your security. See the security right here? Okay. So we always have the security. This is an alarm that babies do not go anywhere. Okay. And because we did this alarm system, it has cut down on a lot of baby snatching that we used to have back in the 80s. Okay. So we want to make sure it's all on there. And of course, the identification band. So baby gets 2 identification bands, one on his wrist, arm, so I'm going to say on the right arm, wrist, and then one on the left ankle. Okay. So it's just that you don't want that ID bracelet to come off that baby. Then mom has the bracelet, then everything matches because it comes in a set of 4. So everything matches. So mom gets the same thing. And then the partner or the father gets the other bracelet, whoever mom has decided who can be in the nursery with this baby. So again, we do not let that baby out unless it has the ID bands and they all match. And this really is like cut back on a lot of things happening up in the nursery. And today, L&D units are locked down and the nursery and postpartum. And you always keep the infant away from the door from the in the room. So, and then we have identification badges that for people who come into these areas, that we actually have to take our badge and swipe it to allow us to get into these units. They really has done a nice job with that. Okay. And then this is about the bladder. So mom, she had decreased urge to void. She may have some birth trauma. Remember we talked about that. And so she just doesn't have it. And an increased bladder capacity, effects of anesthesia on the bladder. So these are pretty important as to what happens to this poor little bladder. Remember, the bladder lays right underneath the uterus. And then you have some lacerations that, oh, she doesn't want a void. Yeah, she says no, but she has a void. So you put that ice pack on her bottom and it feels better. And then you go over pericare with her and that happens. That's better. The reason why you want to make sure she empties the bladder is because distension can cause extensive bleeding. So, and then what happens if you get this bladder distended, it actually displaces your uterus high and over to the side. It deviates it over to the side. And then that can cause that uterus to have what we call uterine atony, or I say atony, A-T-O-N-Y. That's without tone. So if the bladder becomes distended, then the uterus is now displaced. So that's a good text question that could be, on there where, if the bladder, she could not able to void, what do you have to worry about? And the uterus is now above the umbilicus and deviated over to the side, and she's having an excess amount of bleeding, it's because the bladder is distended. Okay. Now, bladder distension increases infection, of course, and impedes the resumption or resuming normal voiding. So you want to make sure that she gets it all out. Now, some women can void afterwards, and so then you have to do some, stray cats and get her going. Okay. When I worked on the postpartum floor, when I was a student nurse, and I help out, I did more Foley catheterizations on that floor, going back, way back. Okay. But I learned how to do it. And I tell you, it was a lot of, they were edematous and they were bruised. Okay. So just to let you know how important that to get her from not having, we don't want her to have bladder distension. Okay. All right. And remember, it causes the uterus not to have tone, because it creates pressure on the uterus and prevents the contractibility. And without that, then she's going to bleed more. Okay. And then this causes this, and then uterine atony, she hemorrhages. All right. So down to stress incontinence is caused by pelvic floor trauma. Remember, whatever you do in the labor room and occurs during the birth process, will take a hit on mom. And so she could have stress incontinence later, even afterwards when she goes home or when she gets older. It could cause some problems with the urinary. Kegel exercises is always good. Kegel exercises help strengthen the muscles for urination. So everyone is easy to do. And it helps, especially when you get older in life, and you have strong muscles. That's good. Okay, and then assist voiding. She should void spontaneously on her own in 4 to 6 hours. So what are you going to do? You're going to, if she needs help, you're going to have warm water, encourage her to void in a cyst bath. When you put that cyst bath on, sometimes that initiates that spontaneous urination. Sometimes in the shower will help doing that. And then, of course, listen to running water. And, sometimes if you put their fingers in some water, it helps too. Okay. So let's move on. Here's the lochia. We talked about this already. So this here, you're hearing it again, which is okay. This is your post-birth uterine discharge, lochia. Now, lochia rubra is bright red bleeding due to primary blood in the first 2 to 3 days. It's all, again, remember I told you it's all according to what book, but there it is, 2 to 3 days. That's what I always go by. And then its persistence suggests retained placenta fragments. That means if you still have a lot of this lochia rubra, okay, she may have placenta fragments. We talked about that. So you have to call the doctor and let them know that she keeps bleeding. Now, when you give like a report to a physician, like the SBAR report, you can say, well, she has a small amount of bleeding. They always want you to quantify. So if she has, say, a moderate amount of bleeding, that's like 10 to 15 centimeters. So that's what I would say. She has 12 centimeters, doc, on the pad. Then he knows that is anywhere between 4 to 6 inches stain on that pad. Now that's pretty significant. Now, if I have a heavy, I say, well, doctor, she has now saturated the complete pad in an hour. That's not good. Okay, so he needs to be coming in. So you can see how this really helps to have this down pat where you have light, you have from like 2.5 to 10 centimeters here. Okay, so that's from 1 to 4 inches. All right, and that's a big Kotex pad. And then here you have scant. That's like a 1 inch. So this would help quantify what kind of bleeding you have. So that helps the doctor to know what he needs to do. And then when you have lochia, you go, as I said, lochia rubra is like the first 2 to 3 days. Then she might go home, right? Okay, so she goes home, and then it should be getting lighter. You know, you've given this education to her, so it should be lighter. Should something happen and say day 14, she now went from serosa, which is the pink, back to rubra. So it reverted back to rubra. That's not a good sign. Okay, it should not do that. So then I would tell them, if you find that you're having bright red bleeding again, then what you need to do is call and you'll come back to the hospital. Because what happens is that could be the placenta fragments of membranes are still there. It was not, so a lot of times too, patients go home like in the first day or two. Okay, so that's where this education really is very much needed, is because she needs to go back to the hospital. Okay, because she could hemorrhage. Okay. Now, sometimes they have a question like that, so you want to read that carefully so that you know that's not normal. And when she goes from rubra to serosa and then she goes back to rubra, that's not a good sign. Placenta fragments, okay, or membranes. Now, the different colors. So you have the rubra first 2 to 3 days, like I said. Then you go to serosa, which is pinkish. You got blood and mucus in there, and that's usually like it's maybe from day 10. So day 3 to day 10 or day 14. That's your serosa time. And then you have, excuse me, you have lochia alba, which is clear or white. So that's mostly mucus. And so that's like through the next 7 days. If it's day 14, you finish the serosa. Now it went to day 15. You got alba, and it can maybe go to day 21 or even more. Don't forget, the postpartum period is 6 weeks. Okay, so what are you going to do? So you have to observe your peripads and your linens. When I have a patient that starts with this heavy business, I start a pad count. And so what you do is you put on like a Chucks, I put in the bathroom, and every time I change a pad, I'm looking at my time. So I'm timing, and I'm looking at how many heavy pads I have. So I can give a really good report and say, doctor, in 15 minutes, she has now saturated 2 pads. Well, that's not good. That's only 15 minutes, right? So she's really having some heavy bleeding. So he knows then when he needs to come in. And then if I have any clots, I have to note the clots. And what I do is I have the size of the clots. So you have from a penny, you have a dime, you have a nickel, and I have a quarter. And that's how I can, again, quantify the size. Okay. And then odor. If it's a foul, blood has its own odor, but it has a really heavy odor, then you know that you got a problem. So that's how you would give, report to a physician. Okay. And then here's postpartum hemorrhage is the leading cause of maternal death and morbidity and mortality. And I told you about blood loss greater than 500 is considered a hemorrhage for a vaginal delivery and greater than 1,000 mLs for a cesarean. I would kind of take note to that. Yeah, could be a good test question. And then you have continuous flow of bright red bleeding or your passage of large clots and saturating more than 1 pad an hour. So the little scenario I gave you, that was quite heavy. Now, I have to be careful of hypovolemic shock or hemorrhagic shock, okay? So you have tachycardia and hypotension. So her heart rate goes up. Now, I would definitely know about this, okay? Her hemorrhagic shock, hypovolemic, which put low volume, blood volume shock. My patient's heart rate goes up, so I get tachycardia. And then your blood pressure will go down, right? And then respirations, and so you go on and on. The most frequent cause of a hemorrhagic shock is uterine atony or uterine atony, atony, because that's a uterus without tone. So what are you going to do? I know you know it. You're going to massage the fundus. Okay, and so you have to also prevent that bladder distension that we talked about, because with bladder distension causes them to have what? More bleeding. So the uterus now is displaced and over to the side. It's often on the right side, so that's why I always said deviate over to the right. And so what are you going to do? Well, you're going to try to get it to void, but if she's really hypotensive, I don't want to get out of bed, so I probably use a catheter. And then another cause of this hemorrhagic hypovolemic shock could be retained placenta. We talked about that quite a bit. And then you also have to consider hematomas, or she had a laceration and they did not repair it in the labor room, the delivery room. So that's another problem, that she could be bleeding from that unrepaired laceration. So doctor needs to be called. And then the second leading cause of postpartum hemorrhage would be those hematomas and unrepaired lacerations. Now, hematomas, bruising and swelling, right? That's blood that collects on the tissues. Like I said, that is painful, and that all can cause them to have excessive bleeding. I don't want to lose my mom about that. Okay, so now we're going to go into attachment and bonding. Okay, so we talked about bonding, skin to skin immediately after birth helps promote bonding. Yes, okay. Rooming in promotes the bonding. And that's more of an emotional tie right after birth, okay? And then attachment it takes a little longer to create that attachment. But you want to, as a nurse, working on mother baby, you want to see how they come together. They have to come to love and accept each other. And then you have close contact after the birth, optimizes child's later development. Yes, this has been studied, folks. And so this has a lot to do with children as they develop, is how they bonded with their mother. And then studies have shown where people who have, deviant behavior and don't like people, they have noticed, they've gone back and done a study where they did never have that bonding or the parental attachment. So that's interesting. And so that's why we want to make sure that mothers and infants, they have the bonding process right away. Now, facilitating behaviors that promote bonding. Okay, so you want to watch and make sure they have good eye contact, touching the baby, holding the baby, and talking to the baby. And it's called ENFACE, ENFACE, where they're actually looking at the baby and talking to the baby. When moms don't do that, we have a problem. Okay. And then you have initiating behaviors hinders or prevents bonding, turns away from the infant or avoids the infant. handles the baby roughly, expresses displeasure in the infant. Now, you might say, who does that? It does happen, especially if I had one patient, to give you an example, where she had like 4 girls and they were hoping for a boy. Now, way back in the 80s, we didn't have the ultrasounds you had today. So we didn't know. And so when the baby came out in the delivery room and the baby was not a boy, it was another girl. She had 4 girls, I think. They were very displeased. Okay. And so she didn't even want to hold the baby. She avoided the baby and she was very unhappy. Yeah, it does happen. So did that baby get the bonding it needed? Probably not. Okay. So those are kind of behaviors that do happen, unfortunately. And the parents took a while to come around. Okay. And again, I talked about encouraging rooming, and that's also very good for bonding. And the nurse assessment attachment behaviors. We want to see attachment takes a little longer. So according to how long you have this, but you want to look for the bonding. Okay. All right. Oh, lipogenesis. Okay. What happens is promoting what? The letdown. Okay, milk production. So you have a fall of progesterone after delivery, which then initiates or triggers the production of prolactin. Write that down, prolactin. Prolactin is the hormone that you need to have in order that the breasts go ahead and prepare and makes the milk. Okay, so you got to have prolactin. And what happens, it prepares the breast to secrete milk in pregnancy and synthesizes the secretion of milk during lactation. Supply and demand and incomplete emptying can decrease supply. So the more mom feeds, the better off it is. Okay, put it that way. But you have to have prolactin. These are kind of questions that may be asked about the hormone needed for, say, for preparing the breast to secrete milk in pregnancy, prolactin. Now, you have oxytocin. Oh, you've heard that before. That's also essential to lactation. So oxytocin allows for mild ejection reflex, which is called the letdown. Maybe you heard that. And or decrease risk of postpartum hemorrhage. Yes, remember I told you put that baby to breast because then she produces more oxytocin and therefore makes you not only is good for baby make for the milk letdown, but also for the contractions. It works good. Okay, now because of the oxytocin having her contract, she has cramping while breastfeeding. So a lot of ladies shy away from breastfeeding because one, it hurts more, but you want them to breastfeed. So how I used to get women to, I should say, excuse me, to breastfeed is one, I tell them they can have an extra 500 calories. Nice. Okay. Then I say, you want to get back in your skinny jeans quicker? Breastfeed, because your uterus will what? Go through the process of involution quicker. That involution is how the uterus contracts and it involutes. It decreases 1 centimeter per day. So I say, hey, that's a good side effect to breastfeeding. So I usually can get them on that. And so they want to get in their skinny jeans. Whatever it takes, we want to promote breastfeeding because why? It provides protective antibodies. Okay. And remember, babies are born with passive immunity for 1 month. So for mommy, so you want to make sure that you protect them, their immune system. And then you have your 3 phases of milk production. And you have the colostrum, and the colostrum is kind of watery looking to mom. And she goes, oh, that doesn't have anything in it. No, that has great antibodies. Yes, feed the baby. Baby's going to be fine. And then you have your transitional milk. And of course, that goes to your mature milk. Moms need a lot of support to initiate breastfeeding. And we have in the hospital, we have lactation consultants, which they are great. They are the experts, and it's a great certification. And they will help tremendously when you have someone who just has a tough time. So we have, this are your resources. And then these are teach feeding cues. Now, these are what we're going to teach mom. So a baby, yeah, babies can't talk to you, but they will talk to you if they put their hand to the mouth like this. You ever see your baby do that? I'm hungry. Okay. How about mouth and tongue movements? I'm hungry. Sucking motions. They're hungry. The rooting reflex. Somebody holds the baby like in a cradle hold, and all of a sudden baby roots right to someone's breast. That's called the rooting reflex. That means I'm hungry. And then mouthing. And every time she breastfeeds, you want to build the confidence. Now, the main thing about when you breastfeed is that you want to watch when they're breastfeeding so that you observe, assess the complete areola in the baby's mouth. And in your book, you have really good pictures of that. And the reason why is because you don't want that baby just to hold on to the nipple, because mom can get sore nipples. Sore nipples get infected and can cause mastitis. Okay, so if the baby has to go to NICU, maybe as a premature baby, mom can pump, and mom pumps 10 minutes on each side every 3 hours. Okay, so breastfeeding is the best, I always say. So signs of effective breastfeeding. Okay, so this here, the mom has the amount of milk she needs. Sometimes you get really a lot of milk production by day 3 and day 4. The milk comes in and you can really feel it. And it goes, oh my gosh. And you want to get that baby to the breast. Firm tucking sensation on nipple with no pain. Uterine contractions while feeding. Remember from the oxytocin. Mommies feel nice and relaxed. Give them lots of water. More water they drink, the more milk they produce. And then the breast should be softened, and they may feel that let down. Remember, again, that's a good feeling, oxytocin. Okay, baby. Baby now, this is effective. That means we're doing everything right, right? So baby latches on without difficulty. Oh, wonderful. And then he has some births of 15 to 20 sucks, and he's swallowing. And you want to hear that swallowing. And then when you're done with feeding, you tell mom to take her finger and put it in the corner of his mouth and release the suck. You always make sure you do that. If you don't, then you just pull baby off the breast. That's going to hurt mom. And then baby, is happy at the feeding, so he got enough what he needs. And then he has at least 3 substantial bowel movements after day 4. Yeah. And I tell you, breastfeeding babies have a sweeter smelling stool than a formula baby. Now, this is how I know if baby is getting enough fluids. He has at least 6 to 8 wet diapers per day. All right. So after day 4. So highlight that or write that down. He has at least 6 to 8 wet diapers, because mamas a lot of times will ask, how do I know my baby is getting enough fluids? And that's how you know. All right, let's move on. Care, the breastfeeding mom. If this is called engorgement. You ever had engorgement or know somebody is painful? And it's usually when the milk comes in, the breasts get really hard. But what you can do, and I would take note to this, you can use ice packs when? Between feedings. Okay, between. And it acts like your anti-inflammatory, and you have hand expression. So, again, ice pack is your best anti-inflammatory. So, sometimes you don't need those medications in there. But if you need to, anti-inflammatory medications will help, because it takes what? It takes the inflammation down. And then you instruct to feed every 2 hours. In the beginning, yes, it's very demanding, so they have to feed every 2 hours. You may have some sore nipples. And remember I told you sore nipples leads to cracks and bleeding due to incorrect latchment. So you want to make sure that you are looking at the latching, and you clean with water after every feeding. Okay. All right. So those are things that you take note. And note too, whatever you eat goes right through the breast to baby. Okay, and I want to touch on weaning. Now, weaning, gradual weaning is preferred. There is no best time to wean. And so you have technique of weaning. So what you're going to do is you're going to eliminate one feeding at a time. So because a baby is attached to mom, you really enjoy the feeding. So it's a special time. So this is hard to do, but you have to do it. So eliminate one feeding at a time. You omit the daytime feedings first. What you do is you eliminate the favorite feeding last. So if say at nighttime, that's a special time with you and your baby, and the baby gets very calm, that's his favorite feeding. Well, I would not, if I'm weaning my baby, I wouldn't choose that one to be the first one to discard, okay, take away from him. So during the day, they're usually not as dramatic as the favorite feeding. Okay, does that make sense? Okay. And then infants will need comfort nursing if they're tired or ill. Sometimes if they get too tired and they just want mom, then they need that. Okay. All right, and remember something, pumping the breast is not advised to decrease the milk supply. No, because when you pump, you're stimulating the breast to do what? To make more. Okay. So let's talk about neonatal hypoglycemia. All right. So here we are, and here's the foot. Do you see where she's puncturing on this baby's foot? You don't puncture in the middle, okay? Because that's where all your nerves are. So you don't want to keep away from that. So on the side of the foot. Now, this hypoglycemia, like we talked about earlier, blood glucose is less than 45 milligrams per deciliter. All right. And if you have a preterm or post-term baby, they are prone to hypoglycemia. And then you have a diabetic mom. The babies, are very prone. And the reason is they've been, with diabetics is what? They've been given, like, for instance, this is the best way I can explain it. They've been getting like a Snickers bar the whole time during pregnancy, okay? And so, I mean, I'm happy. I'm nice and juicy and fat, and I love it. But then you birth me, and then all of a sudden, where'd my Snickers bar go? So what happens to my blood sugar? It goes down, and then you get into that hypoglycemic state. All right. So you have an LGA baby or IUGR, which is intrauterine growth restricted baby. They can get hypoglycemia. Small gestational age babies too. They're small for the gestational age. They can have a hypoglycemic. And mothers who receive tocolytics in labor, that's interesting too. So that baby also has to be like terbutaline or magnesium sulfate. Those are things that, you have to be on alert for hypoglycemic. And of course, if you cold stress your baby, that means that you did not, have your baby in a warm environment. Baby didn't get dried off properly. They're going to use more of their blood sugar to warm their body. So you don't want to ever cold stress a baby. Okay. And the signs and symptoms would be jittery, poor muscle tone. They get diaphoretic. They can have the big one, respiratory distress. They're low temperature. Like I said, you don't want to stress that baby out, cold stress them out. And a lot of times a high pitched cry can be lethargic on you, and they can even have a seizure for hypoglycemic. So you don't want that to happen. So you're going to test that baby's blood glucose, especially when you test it and it's less than 45 milligrams per deciliter, then you better initiate things to do. Okay, now we're almost finished here. So in the math, remember there are 5 math questions in every test and things you might see. So you want to know your milligrams to gram and microgram to milligram. And then ml to administer, mg to administer, and then pound to kilogram, and infusion rate, and intake and output. Ounces to ml, how many ounces in a cup? They like to have that like an INO. Okay, yeah. And then be sure to round when asked, guys. So when the 10th, round to the nearest 10th. So read that carefully, round to the nearest 100th. And so you want to make sure that you have your proper, whatever they want you to round to, that you answer. Okay? All right. Now, these are kind of test-taking strategies. So, again, I always say, Ask yourself, what's the question asking me? Okay. So put the question in your own words. Can pluck the necessary information to reveal the core of the STEM. Again, what is that saying? What's the question asking me? Don't read into a question. Don't make your own question out of that question. Okay. Just answer what they're asking you. Okay. And then understand the question. So make sure you read the STEM. Remember, a question always has a STEM correctly, and notice particularly the way the question is phrased. Is it asking for the best response or the initial response? Big time. Understand what the question is asking before considering the distractor. There's always distractors in there. So take your time. On the test, you have like 75 minutes. So again, understand the question. If the question asks you select all and apply, then you want to see. Okay, go down the list of choices one by one and don't put any extra meaning to the question. Now, if the question is not an all but apply, then don't put down 3 answers, okay? No, it's only if it says all but apply, then you would have some more than 1 or 2 answers. Okay. Now, avoid the what if. I don't do that. Don't read into it. So that's called a what if game. Visualize the client or clinical event. Do not imagine anything beyond what's actually been described in the question. I just said that. So that's really big because a lot of students do that. And they'll go, well, what if? I said, well, that's not what the question's asking you. So remember that little statement. What's the question asking you? And then you have prioritizing questions. You have your airway, ABCs, airway, breathing, and circulation. Then you have Maslow's hierarchy. You have the physiological needs, safety, and psychosocial needs. Okay. And then plan interventions from the least invasive to the most invasive. So we always want to do from the least invasive. And then, of course, there is always an exception in the case of emergency. An intervention may be the first action. Just have to read the questions correctly. Well, okay. So I have some questions, and maybe this will help. And let me read them to you. So this one here, the home care nurse visits a pregnant client who has a diagnosis of preeclampsia. Which assessment finding indicates a worsening of the preeclampsia and the need to notify the primary health care provider? Okay, so here, let me go back. So here we are, where you're a home health nurse. She's got already a diagnosis of preeclampsia. So now, what's the question asking me? Which assessment finding indicates that we're getting worse? Okay, so looking down, so urinary output has increased. Well, no, that's not worsening. What's the question asking me? Dependent edema has resolved. Well, that's okay. That's good. That's not getting worse. Blood pressure reading is at the prenatal baseline. Well, that's not getting worse. The client complains of a headache and blurred vision. Is that a sign of worsening preeclampsia? Yes. So the answer would be 4. There we go. So we got answer correct. Okay. The next question. The nurse is assessing a pregnant client in the 2nd trimester of pregnancy who was admitted to the maternity unit with a suspected diagnosis of what? Placenta abruptio placentae. Which assessment findings should the nurse expect to note if this condition is present? Okay. So again, what is the question asking me? So here we are. This is telling me the little story about her assessing a pregnant who said, now what trimester? 2nd trimester. And she was admitted to maternity unit with they're thinking maybe she has abruptio placentae. So which assessment finding would the nurses expect to note if the condition is present? So a soft abdomen is not abruptio placentae. Uterine tenderness. Okay. Absence of abdominal pain. Well, that's not a placenta eruption. Painless bright red bleeding. Okay, bright red vaginal bleeding. Okay, so what would be the answer? Well, soft abdomen, no. Uterine tenderness, Right. Absence of abdominal pain. And what I know with a placenta abruption, you have pain. So, and number 4 is not correct because that's painless. So I would go with what? Number 2. Let's see if you got it. You should think you got it in this one. Hey, there it is. So here's your test taking strategy. You focus on the subject, the assessment findings, and abruptio placentae. Remember that the difference between placenta previa and abruption involves the presence of uterine pain and tenderness with abruptio placenta as opposed to painless bleeding with placenta previa. So that's how you take it apart. Let's do another one. The nurse is caring for a client with preeclampsia who's receiving an IV infusion of magnesium sulfate. Okay, so we got preeclampsia and she's getting magnesium. So when gathering your items to be available for the client, now which highest priority items should the nurse obtain? So this is your highest priority. Okay, so we know that, we have to be careful with magnesiums, so we don't want to get toxic because toxic, we would lose her respirations. So a tongue blade is not my highest priority. Percussion hammer is not my highest. Now, these are things I probably want to have at bedside, but they're not the highest priority. Potassium chloride injection. No, we don't want that. That's not my highest priority. The calcium glucate injection. This is what I want to have at bedside. That's my highest priority. And the reason why is because that's the antidote for if you overdose on magnesium sulfate. So let's see if we're right. Oh, let's go here. There you go. 4. It's because you have toxic effects of magnesium sulfate can cause a loss of deep tendon reflexes. It can actually cause heart block, respiratory paralysis, and cardiac arrest. So the antidote for magnesium sulfate is calcium gluconate. Okay? Again, all the other ones probably nice. I mean, a percussion, a tongue blade is good. You can have it, because it's an airway. Percussionist hammer, okay, yeah, to assess reflexes, but it's not the highest priority. Okay. And of course, I wouldn't have potassium chloride, I bet. All right. How about we do another one? All right. A 35-week gestation pregnant woman is transferred to the maternity unit from the emergency department. Okay. So she was treated for minor injuries sustained in a motor vehicle crash. She had a car accident. What's the maternity nurse's priority will be to assess for which complication? Okay. So remember, we talked about this. So she was in a car wreck. What can happen to that placenta? It can come right off the wall. So it would be a abruptio placentae. There you go. Answer is 3. Trauma increases the increased risk of miscarriage, preterm labor, abruptio placentae, and stillbirth. All right. That's why you have a car accident. Even though moms always say, oh, I'm okay. We always say you're going to the hospital. Okay. Now, following the next question, following the vaginal delivery of a 10-pound infant, the nurse assesses a new mother's vaginal bleeding and finds that she has now saturated 2 pads in 30 minutes. Remember those pads I showed you a picture of? And now she has a boggy uterus. Not good. She had a big baby. So which actions should the nurse implement first? What do you think? I have a big baby. And I have vaginal bleeding, and I've saturated 2 pads in 30 minutes. That's a lot of bleeding, and I got a boggy uterus. Oh, I should massage that. So massage the fundus until it's firm. Is that correct? And that is correct. All right. If the uterus is not contracted firmly, the initial intervention is to massage the fundus until it's firm and to express clots that have accumulated in the uterus. Now, if elevating the client's legs and position the client on the side would not assist in managing a uterine atony. So that's a uterus without tone. So yeah. And then pushing on an uncontracted contracted uterus can invert the uterus and cause massive hemorrhage. Yeah, you don't want to do that. No, you don't want to invert a uterus. Okay. Question number 6. Now, this is a select all that apply. So if the labor period lasts only for 3 hours, the nurse suspects that the following conditions may occur. Again, select on apply. So could I have a laceration of the cervix? Yeah, well, what is this? What is this describing here? This is describing a precipitous labor and birth. So I know that a laceration of the cervix can happen. A laceration of the perineum can happen. I can get a vulvar hematoma because she's delivering too quick, and also precipitous labor I know can lead to postpartum hemorrhage. But then I choose all that apply, so I would choose all of them 1, 2, 3, and 4. Let's see if I'm right. You think I'm right? Yeah, 1, 2, 3, and 4. Okay. Remember, all these can occur with precipitous delivery. Lacerations to both the cervix and perineum occur due to baby delivering so quickly. Now, postpartum hemorrhage occurs due to the potential for uterine atony after the uterus has been hypertonic in labor, and we discussed that. Okay, question 7. The nurse is monitoring a postpartum client who is bleeding for signs of shock. Okay, which indicates an early sign of shock. Okay, remember I told you to know this. All right, so she complains of abdominal cramping. She has an increased pulse rate of 80 to 100 beats per minute. She complains of feeling tired, yet is feeling hungry. An increase in the respiratory rate from 18 to 22. Okay, so what's my early sign of shock? Is remember the pulse what? Goes up. So I'm going to choose number 2. So let's see if I'm right. Yes. Okay, so during the 4th stage of labor, the maternal blood pressure, pulse, and respiration should be checked every 15 minutes during the 1st hour. So remember this, a rising pulse is an early sign of excessive blood loss because the heart, what's it trying to do? It's trying to pump faster to compensate for reduced blood volume. The blood pressure will fall as the blood volume diminishes, but a decreased blood pressure is not the earliest sign of shock. All right. All right. When administering magnesium sulfate to a client with preeclampsia, the nurse understands that this drug is given to what? Okay. Now, this has always been a good test question. You give magnesium to someone with preeclampsia so they don't have seizures. That's the answer. Yes. Magnesium sulfate is used to prevent seizures in the preeclamptic woman. Now, like a side effect, I say it might reduce the blood pressure a bit, but it's not used for that purpose. And so many students in the past have gotten this wrong because they say, oh, lowers blood pressure. No, I am emphasizing that magnesium sulfate is used to prevent seizures in the preeclamptic woman. Okay. Question 9. The nurse is caring for a post-term large gestational age, LGA, newborn infant immediately after admission to the nursery. What should the nurse monitor as a priority? Now, we talked about this. So which one do you think it is? Would it be urinary output, total bilirubin levels, blood glucose levels, or hemoglobin hematocrit? Remember, it's a post-term large baby. And you're immediately after admission to the nursery, I would be looking at blood glucose levels for hypoglycemia. And there it is, answers 3. So a common metabolic complication in the large gestational age newborn is hypoglycemia, which can produce central nervous system abnormalities and intellectual disabilities if not corrected immediately. Remember, is this a problem in babies, hypoglycemic? Yes, it is. And you can cause him to have problems in his central nervous system and intellectual disabilities if not corrected immediately. Okay. All right, how about this? The home care nurse's assignment is to visit a new mother at home 24 to 48 hours after discharge. Okay, this lady wanted to go home quick. So what should the nurse expect to note in a healthy mother who is breastfeeding her newborn infant? Okay, so, all right. The mother has cracked nipples and feeds the infant with a supplemental bottle. But now, what's the question asking me? The question is asking me, what should the nurse expect to know in a healthy mommy who is breastfeeding her newborn infant? Okay, well, that I'm going to cross out the first one. The mother complains of breast engorgement and the infant demonstrates difficulty latching onto the breast. Okay, well, this one, the question's asking me, all right, she's healthy and the baby's doing good and she's breastfeeding her baby. So there's no problem. So that one's out. The mother is breastfeeding the infant with the infant's head turned toward her breast and the body flat in her arms. The mother has sore nipples and the infant has a suck blister. Well, that's not good. Remember, what's the question asking me? And the last one is the mother is breastfeeding with the infant in a tummy-to-tummy position without signs of cracked nipples, and the baby demonstrates bursts of sucking followed by a pause and a swallow. Remember, this is the healthy mommy and breastfeeding her newborn. So which one is the most healthy of all of them? Is 4. So let me see if I'm right. Yeah, I'm right. So the infant should be positioned completely facing the mother with the head, neck, and spine all in alignment. Poor positioning increases the number of attempts for latching on. The infant's head turned toward the breast and the body flat is incorrect. Okay. And remember, cracked nipples, breast engorgement, and sore nipples are all complications that result of what? Improper positioning. So you can see when I'm answering these questions, I'm going back and answering myself, what's the question asking me? All right, so which of the following circumstances is most likely to cause uterine atony or atony and lead to postpartum hemorrhage? Okay, this is question 11, all righty. So we talked about this, most likely to cause the uterus to have no tone. Well, it wouldn't be cervical and vaginal tears. Well, urine retention, yeah. Remember distension of the bladder, hypertension, or endometritis. So which one was most likely to cause that uterus not to be toned? And that would be what? Urine retention, right? Okay, it's just another word to say the bladder is distended, correct? Okay, there you go. Urinary retention causes the bladder to be distended and put pressure on the uterus, decreasing contractibility and can lead to atony. All right. A nurse explains the breasts of a prima parvis breastfeeding mom, that's a first-time mommy, who is 1 day postpartum. Okay, she's 1 day postpartum. So an expected finding would be on this prima gravida breastfeeding mom, is she's 1 day, would be what? Okay, it'd be soft, non-tender colostrum is present. Well, we know that colostrum is an expected finding, but let's go see. Leakage of milk I'd let down. Swollen, warm, and tender upon palpation. Now, this is who's 1 day, because that's too soon. A full blister, few blisters and bruise on each areola. Nah, that's not 1 day. Okay. Remember, milk don't come in that fast because this is 1 day. So the only one that you can choose is the soft, non-tender colostrum that's present. All right. See how I went back up to the question? And I'm asking myself, what's the question asking me? Let's see if I'm right. Number 1. There we go. So you see, write this down. Mature milk does not come in for 3 to 4 days after delivery. So the colostrum is present initially. All right. And the other findings are concerning, but that's what's the question asking me? 1 day. Okay. Let's do another one. I got a few more, not too many, and then I think we'll be done. Which instructions in the discharge teaching plan assist the patient in recognizing early signs of complications? Okay. So again, what's the question asking me? So it's asking me in the discharge. So which instructions in the discharge teaching plan assist the patient in recognizing early signs of complications? Okay. So would it be palpate the fundus daily to ensure that it's soft? No, we want to make sure it's firm. So that one's definitely out. The passage of clots as large as an orange can be expected. No, well, hopefully not, right? Okay. Report any decrease in the amount of brownish red lochia? No. How about reports increase in the amount of lochia or return to bright red? Gee, I think we said that, right? This is why very important. So let's go see if it's number 4. Yes. So the fundus should be firm. We said that. The passage of clots is not expected. It is important to report locally changing backwards. It should progress as rubus or serosa to alba. This can be a sign of subinvolution and hemorrhage. And subinvolution that's where there's something that's causing that so the uterus does not involute, which we know involution is a return of the uterus to its pre-pregnancy state. Okay. How about we do another question? How about question 14? We've got a couple more and that's it. So 2 hours post-delivery. The fundus is 3 centimeters above the umbilicus and to the right. Oh. What can bladder distension cause postpartum? Oh, we know that one. Would it cause bladder wall attening? No. A ruptured bladder? Excessive uterine bleeding? Urinary tract infection. Okay, so let's go back up to the question. What's the question asking me? So we're 2 hours post-delivery. The fundus is 3 centimeters above the umbilicus. Well, we know that that's not right. We shouldn't be there. It should be at the level of the umbilicus. And now it's to the right. What's pushing it to the right? Let's see. So what can bladder distension cause? Okay, so the bladder is distended. What does that cause? That causes her to have more bleeding. And we know that. So let's go down to choices. And I would choose number 3, excessive uterine bleeding. You see how I took that question apart? That's how you have to look at these questions. Oh, I'm right. Answer is 3. Okay. Question 15. Which hormone is necessary for milk production? Oh, remember that? Is it prolactin, estrogen, progesterone, or lactogen? Which hormone? And we know that is prolactin because we studied that. So 15 is number 1. Let's see if I'm right. Yep, it's number 1. All right. The last question. A mother asked if she should feed colostrum because it's not real milk. What would be the most appropriate answer? Well, we know that colostrum has a lot of antibodies. So do we want her to feed that to the baby? Yeah. So let's see now which one. So colostrum is unnecessary for newborn. Well, we know that's wrong. Colostrum is low in calories and should be supplemented by formula. No. We don't supplement by formula. Colostrum is high in antibodies, proteins, vitamins, and minerals. Oh, I think I know that one. But let's see what number 4 says. Given colostrum is important in helping the mother learn how to breastfeed. Now, so I know that colostrum is high in antibodies. It's high in proteins, vitamins, and minerals. So I would choose 3. And that's correct. Okay. So that concludes. Let me stop sharing. That concludes this comprehensive exam 2 prep. And I know that we spent a long time, and so I thank you for that. And so be sure that if any of these concepts are something that you're not sure about, you go back into your textbook. Okay, I want to conclude. Thank you. And I'm glad that you enjoyed it. You're very welcome. Thank you, Pam. Okay. All right, everybody. Everybody have a nice afternoon, and I wish you only the best. Keep studying. Bye-bye.